Hello, and welcome to this presentation, Ensuring Access to Affordable Quality Care Across Rural Minnesota in 2030, Financial Projections and Recommendations. I am Cap Wilkes, Director of Program Development at the National Rural Health Resource Center and a member of the project team. This presentation presents the financial projections and recommendations resulting from this study. I will start by providing a brief introduction to our project as context for the financial projections and recommendations that have been developed by Stroudwater Associates, Eric Schell, and Dan Given. Then turn it over to Eric and Dan to describe their approach, assumptions, and projections. This presentation is about 1 hour in duration. Please note that the information provided in this presentation can be found in our report and appendices. With funding from the Mayo Clinic Foundation, the National Rural Health Resource Center is partnering with the College at St. Scholastica and Stroudwater Associates to conduct a study examining trends and disruptors within the rural healthcare environment that will influence access to affordable quality care across rural Minnesota in 2030. Our project team brought a range of expertise in rural health, healthcare quality, data analysis and data modeling, financial modeling, value-based and historical fee-based payment models, research, leadership, facilitation, and group process design. Stroudwater Associates has been a partner with the Center for many years. We recognize their depth of knowledge in the area of rural healthcare finance. Stroudwater has significantly contributed to understanding and development of value-based models across the country. Eric Schell and Dan Given have developed a financial model for rural healthcare in Minnesota based on the results of this study and their extensive experience working within the rural healthcare environment. The goals of this study were to illustrate interacting components of health in rural communities, provide a framework for planning that has been informed by data and knowledge, provide scenarios that are forward-thinking in a changing environment, and identify options for rural health policy development in Minnesota. The process of envisioning a healthcare system where the three attributes of access, affordability, and quality are available in rural Minnesota communities was complex and required a systems approach. Acknowledging this complexity, the project was oriented toward participation from a wide variety of subject matter experts and structured on a concept of change that kept the vision in the forefront. Throughout the design and implementation process, the vision served as a beacon to orient learning, discussion, and prioritize ideas. Rural health leaders with diverse roles, perspectives, and expertise shared their knowledge and insights as an integral part of the study. Most participants represented a Minnesota perspective, but some came with a national point of view. Represented areas of expertise included primary and specialty care, mental and behavioral health care, critical access, hospital and clinic administration, emergency medical services and rural policy, quality improvement, technical assistance, and foundations. The project team wishes to acknowledge the contribution of these leaders to this study and thank them for sharing their time and expertise. Acknowledging that cookie-cutter solutions are not long-term solutions, our study started by exploring 4 representative rural communities, case studies for forward thinking. Community profiles were designed to focus our thinking about trends and characteristics that both support and reduce access, affordability, and quality in rural communities. The 4 community profiles were created as case studies by combining data from multiple communities to illustrate the diversity of rural communities across Minnesota. For example, Alphaville represents a community that is growing and being influenced by a metropolitan area. The local healthcare facility owned by a health system is a critical access hospital with a primary care clinic and emergency department. As part of a large health system, residents have access to integrated services encompassing both physical and behavioral health. Prairie represents a community with a changing demographic. The local 48-bed hospital is owned by a health system. Many specialists work full-time at the Prairie facility, and additional specialists are employed by the system and visit the facility on a regular basis. Surgical services are offered on site, as are emergency care, home care, and hospice. Charlie Pines represents a small community that is quite isolated. The local healthcare facility, a critical access hospital, is county-owned and houses a long-term care facility and an emergency department. Neither surgical services nor OB services are available. 74% of its revenue is generated from outpatient service. Delta Lake represents a community with a diverse economy. The local healthcare facility, a critical access hospital, is an independent entity that partners closely with a regional health system. It houses a primary care clinic, long-term care facility with a memory unit, pharmacy, small surgery unit, and emergency department. Our exploration started with finding a vision that makes sense for rural communities, which allowed for discovery of trends that describe the environment we are living within. That led to identifying disruptors, acting as a framework for finding recommendations that make sense for rural communities in Minnesota. Recommendations that policymakers and change leaders can lean on to focus effective solutions. The vision of a healthy rural Minnesota acts as a beacon, guiding decisions as ideas are transformed into projects and processes within the complex system of healthcare. Anticipating trends of rural healthcare in communities describes the environment we are living within and helps to monitor progress toward our vision. Disruptors are an event, decision, or activity that can affect current trends. They push for change by enabling a new way of thinking, altering how we respond and the decisions we make. Here is a summary listing of the 6 key disruptors that were identified through the study. Going forward, these 6 key disruptors have been used to categorize recommendations. These disruptors illustrate interacting components of health. They provide a framework for our study to develop specific recommendations. To ensure the key disruptors do their job of influence and changing trends as we reach toward our vision of health across rural Minnesota in 2030, our study has 30 recommendations for policymakers and change leaders to incorporate into their work. Several of them focus on the key disruptor, innovative rural population healthcare, and payment models that ensure viable health services within rural communities and address financial pressures. Our partner, Stroudwater Associates, in the following presentation, shares their thinking and insights on this disruptor and others as context for the financial model and projections they have developed for our 4 case studies of rural Minnesota communities. As our Stroudwater partners say, we want to have a payment system that pays for the functional imperative of the system and the form that is put into place to achieve that function. Translating that to our study, our vision, describing access to affordable quality care, acts as our beacon. This in turn informs and inspires how we will deliver this vision of care, the form of care, which in turn directs the financial system we are required to put into place to pay for the care system we want. Welcome, Eric and Dan from Stroudwater, to our project, Ensuring Access to Affordable Quality Care across rural Minnesota in 2030, where we're creating recommendations for policymakers and change leaders. And we're really glad to have you here. I'll turn it over to you now, and I'm looking forward to your presentation.
Yeah, thank you. And actually looking forward to providing some of this information. Yeah, I think the goal of this was to take what you guys came up with in Disruptors and use them as key inputs into a financial model that would be sustainable carrying out into 2030. And then, kind of demonstrating that in the 4 communities, you guys, the Alpha, the Delta, the different, the Charlie Ponds, et cetera, to see what that would look like. And so that's the goal of this. So anyway, this presentation, the first part of it is just trying to incorporate in some of the disruptors that you all come up with, and then some of the information that we've been looking at Stroudwater for a while. I think there's a lot of words on this one overview slide, but I think it really hits home at some really key points. That that, currently our fee-for-service, and it's fee-for-sick care services, is the payment system that predominates our healthcare system. And providers have organized around the functional imperatives of this fee-for-sick care system. And the functional imperatives in the payment system that we have, frankly, are if an organization can maximize sick care utilization, if they can maximize the price that get paid for each of those units of utilization, and if they can manage expenses, provider organizations can do this in a vacuum. They can do this on their own. And because of that, we are where we are, with healthcare costs continuing to spiral out of control, a focus on sick care, and anything that we do to create healthcare gets us in trouble. And so, and that's the fee for sick care payment system does not promote healthcare and specifically excludes any investments in healthcare. And so, current healthcare disruptors are kind of market forces, technological innovation, and changes in regulation as we're seeing coming out. The Chart Transformation Act, plans that just came out 2 weeks ago. They've all begun to dislodge this traditional fee-for-service or fee-for-sick care payment system. What our belief is we kind of this world of form follows function follows payment. And again, the payment system of fee-for-sick care, we've organized ourselves to maximize sick care utilization, sick care price, and to minimize cost. What we believe is what happens if we said, let's set payment at the back of the bus, and ultimately designed a healthcare system for our rural communities that we could apply the entire resources that we have now applied to sick care and share them between creating healthcare and maintaining access to sick care. And ultimately the model that we've developed here is a payment system that we believe improves the health of the community while maintaining access to sick care. So there's a lot of words on this. I'm not going to take this much time on other slides, but I do want to say the main point we want to make here is that we fundamentally believe if we're going to get payment right, let's set it aside, design function first. What is it that we truly want? Then figure out the form it's going to take to make that, to meet those functional imperatives. And then we'll figure out how to pay for it. That's how we came up. That was the thinking that Dan and I came up with to come up with the model that we have here in front of us today. So challenges to this system, and we've got some slides to talk about this. The increased cost to consumer. We got a slide on the declining hospital volumes, financial pressures, regulations. All of these kind of are these part of these disruptors that you all have come up with. Hospital closures, we're seeing this. We're at 131 hospitals, and this was as of the middle of March, the middle of July. I just asked one of our analysts to update this. I believe there's been 3 more closed here in the last couple months, and so we're getting this going to be updated. But you got hospital closures here. Those hospitals that are in this fee-for-service world that can't access enough sick care utilization are starting to go by the wayside. We talked about increasing price, and you guys identified this as a market disruptor in that the cost of healthcare or sick care, if we will, has continues to go up. And guess what? There's no end in sight. And if you think about the functional imperatives of the fee-for-service payment system around maximizing sick care utilization and maximizing unit price per sick care utilization, these trends are going to have to continue to support our sick care system. And so, a change in the payment system that changes functional imperatives will allow us to bend this curve, in our opinion. We have co-insurance. We used to think that once we got the patient had the decisions that they made regarding accessing healthcare or sick care services had a direct impact on their pocketbook. That we used to say, hey, once we get this all straightened out and patients feel some pinch when they access sick care, that we're going to solve healthcare. Well, obviously, we've got now we got 68% of small businesses and have high deductible health plans, which means there is that pinch for consumers. And guess what? Going back to the previous slide, it's not working. And then you say, why? You've got decreasing inpatient volume. We live in this world, right, of fee for service. Price times volume is revenue. And what we're seeing now over the last kind of 20 years is a declining inpatient volume. More recently, this was reported in January of this year by American Hospital Association. This is the first time since 1983 did we see a decline in hospital outpatient visits. And with this decline, the business didn't go away. What happened is the business to the hospitals went away in lieu of urgent care centers, Amazon.com and Halo, and kind of all of these new technologies that are now taking on the role of, quote, the hospital. And so again, price times volume is utilization. We start looking at the declines in inpatient, outpatient utilization. This fee-for-service world that we're living in is becoming a challenge, as played out by hospital margins. This is Medicare margins in rural hospitals, and then the gray line is all hospitals between 2010 and 2020 projected. The source for this was the MedPAC report to Congress issued on March 15th. And you can see that the overall Medicare margins are going down. So here we are, sick care utilization on sick care price, and and then result when declines in utilization and declines in price relative to cost. We're seeing these Medicare margins decline. Now this uptick, just that small uptick that you see over here on the right, if you actually read the Medicare MedPAC report, what they talk about is that some of that is that there was a small uptick in inpatient coding, as well as the 340B program that has buoyed some Medicare margins in hospitals. And then we're seeing the spread of the ACOs from a regulations perspective. So the ACOs are all being pushed by SEMA Verma and CMS, CMMI. Matter of fact, the MedPAC, the June MedPAC report to Congress literally said that the trust fund will run out of money much sooner than we expected, and we have to accelerate with any possible way a movement into either accountable care organizations or Medicare Advantage plans. The current system is not working. So kind of some of these disruptors, disruptors that we're seeing out there, new entrants, substitution, consumer-driven healthcare, and all of these, and alternative payment models, all kind of key disruptors. You all hit on many of these. The new market entrants, corporations that are saying enough is enough. Now, kind of recently, Haven is actually seeing some of the departures of senior executives, but here is a industry. Large companies are ultimately saying, you guys, costs keep going up. There's no end in sight. We can't do it you can't do it anymore. We're going to take this on, and kind of partnerships to provide healthcare organizations. One of the things they talk about here is first we're going to figure out how to provide it to our own employees, and then we're going to figure out how to do it for everybody else. But we got substitution going on from new market entrants, new technology, and what the new technology has been doing with substitution. Here's an example of a lab company or a lab that you can buy these online. These are lab tests that you can do in-home. You can send the results to approved physicians at certified labs, all types of different tests, and they're available at Target, CMS, CVS, Humana, and otherwise. Bread and butter rural hospital business is their lab services. It's where you can generate sick care contribution margin, and this stuff is now going to substitution. New technology here. I'm hearing more and more about this. Matter of fact, the Stanford Health System announced a partnership with this Untitled, where this provides kind of at-home diagnostic testing for patients, all through technology. this is stuff that, all of this was coming into our hospital outpatient labs, our rural health clinics, our physician clinics, into our labs, and now this is stuff that through technology can be performed at home, and clearly, kind of a market disruptor. So here's, first of all, any questions on any of this? I do think it echoes a lot of what you all came up with in each of your task force meetings.
Yep, I think so too, Eric. And it's really well aligned with the trends and the disruptors that we identified, and not just us, but our findings from our summit participants, who are rural health experts from across the state, and some national representation too. So yeah, so far really well aligned. Any other thoughts or questions?
This piece of this thing, and what I say is that this first piece right here, so is under this payment system one, we're going to lose 5% of rural hospitals, and the market's going to create this. It's a market forced closure, because the payment system is moved, and these hospitals are not going to figure it out until it's too late, and they're going to close. We've already lost 131 plus, maybe probably 134 by now. I'd say we're going to lose 5% of rural hospitals. When we move down here, I would think that there's another 5% of rural hospitals that we're going to lose here that haven't figured out that your primary care base is your revenue centers. There was a classic case in Michigan back several years ago where going up towards the UP, I forgot the name of it, where a big health system went in, picked off all the primary care of a critical access hospital just before the bridge, before you went over the bridge to the UP, and then closed the hospital. And so once you pick off the doctors, so I think there's going to be another 5% of rural hospitals close here. I think there's going to be 10% close on this last one, but this one and this one, the market closes the hospital. On this initiative, the 10% that are going to close, it's going to be a resource allocation decision that is in the best interest of the community. And what I mean here, I'll give you an example. So this whole shaky bridge and this whole thing came out of working with 4 critical access hospitals in northern New Hampshire back, 5 or 6 years ago. 4 critical access hospitals, 2 county area in northern New Hampshire. As they started talking about it, 2 of the hospitals in this very small region were doing 24/7 general surgery. There were 4 of them all together. As we started talking about, as they came together, and all of a sudden, we started talking about the fact that as the payment system evolved, and payment was in the form of just per capita, for every 30,000 population, you're going to get $10,000 per head. Do we really need 4 critical access hospitals, or do we need 2 urgent cares and then 2 hospitals with more full service? And so, do we need 4 critical access hospitals in this small 2-county area when all payment comes in on a population basis, and then we make resource allocation decisions on where we invest sick care and healthcare resources? So I think it's the shrinkage of the more efficient delivery is in this section right here, and I think we're going to lose 20% of hospitals. We should.
Hey, Eric, just another point, and I don't think this is just confined to hospitals. I think it applies to health systems as well, that the competition between larger healthcare system isn't going to intensify. And I think it's very predictable. We'll have there'll be consolidations happening. And then the other fact I don't think you've spoken very much about is we're going to do less sick care, meaning it's going to shrink because of that as well. If we keep people healthier, they're not going to use as many of our resources, but we're going to get paid for it under a capitated system.
Yeah, exactly.
No, I appreciate you elaborated on that, because it really caught my attention. We're worried, in our report here, we're really worried about access. And so when we're building this, we're promoting this model that's going to reduce really access. Well, the access is just going to look different, is what you're saying.
That is my belief. Now, let's just say you go up to Grand Marais, 2 hours from civilization. You need access there, and what that access looks like, you need some beds. You're gonna just because of where they are, and that, a very defined population, remote. We're gonna have to maintain access to kind of a hospital that's there right now. And so, but I do see them, ultimately becoming part of a larger system as we start to kind of move it towards the payment over here on the right, so that they can diversify insurance risk and become part of something larger. Let me keep going, because this is where, so back in 2014, I gave a presentation in Hawaii, and I called it Hawaii Healthcare 2020. It was pretty funny because, I was actually flying out to give this talk, and I started thinking about, maybe we have this wrong. What happens if we started with the end in mind and worked backwards? What happens if we said, really, in the end, if we're going to create a healthcare system that was the right vision, and I started thinking about, isn't the vision, rural Minnesota health system partner with the community to improve the health by preserving access to appropriate sick care, and flip this thing around and start with what we wanted, and then figure out how to get there. And on this flight to Kauai, this is when I started getting this thinking. And so if you look at this, the slide and where we started with payment, function, and form, let's throw this thing, let's just throw this away and say, wait a minute, let's put finance as the caboose. What is it that we want for Minnesota, rural Minnesota in 2030? If we figure out the function, what is it that we're looking for? We'll figure out the form. What does that form take? And then with those two in mind, we've got to create a payment system that funds what we want. And so as I started, thinking about this, and then it was great because this was something that had been, I gave an updated version of this presentation last October out on the Big Island. And then you guys came along with this project, and it was great because you guys are thinking exactly like this. What is it that we want? And this is what we came up with. Rural health systems partnering with the community to improve the health of the population while keeping access to traditional sick care. We still want to have that high quality sick care, but is there something else that we could be offering? And that means, chronic disease management, increased relevance of our health system in healthcare. And in addition, access to appropriate and right-sized traditional patient care. This is what we want: right care, right time, right place, right provider. Evidence-based protocols ensure safety, quality, and patient safety are critical. This is what we want out of sick care. This is what we want out of healthcare. Between the two of them is where we want to put all of the resources, the $3.5 trillion of resources right now, they're going to sick care. Let's share. Let's share between healthcare and sick care. As we was thinking about it, some of the requirements we're going to have to, if we're going to do this, it has to be driven by somebody, or the fee-for-service incentives and wherewithal and understanding will drive us. And so we really have to come up with a common vision for where we want, and hopefully it looks like this. And then we have to have a payment system that provides incentives for healthcare. We don't have that right now. We do not have that. The good news is the chart and like the global budget model in Pennsylvania and some of these experimental models that are coming are starting to move in that direction. Okay, so that's the function. What's the form look like? Well, in order to do that, we need high level of integration, which we don't have now. Now in Minnesota, you guys are starting to roll up a little bit. But there are many of independents. We've got to partner with non-traditional partners, primary care with patient attribution. We've got to start having lives attributed to the healthcare system instead of insurance companies. And right now, as long as lives are gone to the insurance companies, this is where it all, in my belief, is where we got off track. We have to have new roles for our health systems, and they have to take on claims analysis, network contracting, risk management, risk contracting, essentially taking on those insurance functions. And the integration of payment and delivery system. This is the form. Essentially, going back 2 slides, it's the form that's required over here. This is what we want. And then some of the requirements: patient lives, enough lives to diversify insurance risk, centralized decision-making to right-size the delivery system. This gets back to the comment, Brandon, I made with onto your question. In order to truly say, all the dollars are coming in the form of premium dollar, $10,000 per population, with centralized decision-making, like a large system that has 30 hospitals in it. That system then can take those premium dollars and decide, do we really need 4 critical access hospitals in a 2-county area? Or is it more appropriate to put a health center in, 2 urgent care centers in 2 of those communities? What does all that look like? Well, we can't start to make those decisions as long as the resource allocation decision now is based on sick care claims. And then current common information technology platform, which actually, kind of the final rules around the technology integration that came out in March of this year is going to move us in this direction. And then, okay, so if that's the function that we want, and the form, that's the form that we're going to get to meet the functional imperatives. How do we pay for this? And the payment system must fund necessary access to healthcare while preserving sick care, patient care. And its payment systems cannot preclude health interventions. I would suggest to you today that the fee-for-service world that we in fundamentally precludes health interventions. I mean, we give lip service to, all of our boards and all of our hospitals have this thing around, we're going to create the healthy communities and we're going to be part of health in our communities. And then when we look at their actual resource allocation decisions on where they spend their $50 million budgets, there's not a whole lot of dollars in that. At the same time, the payment incentives cannot preclude access to sick care. We've got to have high quality sick care. So starting with what the payment system can't do, I think it's sort of the basis of where we go. Our financial reporting to reflect income for both healthcare and sick care. Right now, anything that we do to improve healthcare in our financial statements results in a loss in financial performance. And so we've got to be able to recognize income for both healthcare and sick care. So the requirements are nearly 100% of global payment to healthcare providers based on attributed population. Now, so that is how we think. And this may require providers to assume insurance risk. One of the things in my talks recently I've been getting away from is actually I've been moving away from risk. I think risk is a phenomena of the claims-based payment system that we're in. What I'd like to think about is when we start taking on $10,000 per head as a payment, what I want to start and move away from the idea of risk and start calling it the residual claim on health. In other words, if we invest appropriately in healthcare and healthcare and sick care resources, and we can bring the costs down, dollars out of pocket spent on healthcare and sick care resources, if we can bring those down to $8,000, the residual claim on our creating health is $2,000. Let's stop talking about insurance risk because everybody's afraid of that. Let's start talking about the residual claim on health. So move on, financial reporting methods to be adopted to new payment. In other words, credits on income statement for improved population health. And then new cost centers and the new cost centers, as we start to move this world, are essentially the areas where we invest in healthcare and sick care resources. Those are our cost centers. Let's give them a budget and manage to it. And you're going to start to see, if you're hearing all of this, this is the language and our thinking is how we came up with the payment system that Dan and I have modeled out here. So short-term, proactive approach to determine vision for rural Minnesota. And, can we get the governor's office? The Healthy Washington initiative back several years ago, the governor's office led this whole thing around something called, coming up with this vision for rural Minnesota. We got to step aside from the current challenges because they're all consuming. And the current challenges, I'll just put COVID-19 as one of them. And right now we got everybody focusing all their efforts on COVID-19. 5 months from now, there's going to be something else that's going to be current, these all-consuming current challenges, and we've got to set them aside if we're going to figure this out. Our rural healthcare providers are going to have to accumulate scale and centralized decision making. We have to start developing the frameworks for integration, such as PHOs, where physicians and hospitals come together, bringing in post-acute care, other things. And then we have to start this partnership with commercial insurers. And it's just so funny that today Blue Cross Blue Shield of Minnesota came up with this announcement with Alina around this insurance plan. So with all that as background, any thoughts or questions? Because the rest is really, what we're going to do is just maybe go through a couple of the financial models, because it's all the same financial system.
Thank you, Eric. Well, thanks for that explanation. And I think you're right on. Our project is 100% aligned with your thinking on this. And what we did over the past several months is work on articulating that vision. And what do we imagine health care, both sick and well care, looking like in 2030 in our rural communities across Minnesota? So it's really nice to have that explanation, and many of your thoughts really truly are represented in the summit's disruptor descriptions and also recommendation descriptions. And so great to hear it from your perspective.
Yeah, like I said,
I'd like to jump in here because historically, healthcare finance has driven everything else we're talking about here. So I think it's incredibly important, whether you put it first or last. And we got this in the comments, remember, at the end of our meeting of our participants, is that we can create this wonderful vision, but if we can't make the finance work, then it's an exercise in futility. So however we're putting it in this particular place, personally, I still feel better with putting finance will drive the innovation, and finance and value is going to create the form that we're looking for. But I think we have to have both in that regard. So there has to be that vision of where we want to go, but the finance definitely has got to work. And there was a lot of cynicism that I picked up because we've come up with these great ideas before. This isn't the first time where a group of people have sat down. There was 2020, Minnesota, there was 2010, back before that, we looked at the year 2000 moving forward here. But I think the big part about this is the money, the finance has got to work, and it's got to reward the things that we're talking about, or they're simply not going to happen. Altruism is simply not strong enough to drive what I think we want to accomplish.
Well, Terry, so you and I've had these conversations in the past. I completely agree that the payment system, we've got to get the payment system if we're going to get the function right. What I wanted to do, or what the way we were thinking about this, is if we just said, what is it that we want? Let's just close our eyes and picture the perfect rural healthcare system. What would be the things that it would afford? I mean, what would we have? And it came down to two things. An investment in creating healthcare and access to sick care, those two things. The purpose of the exercise we just went through was to say, okay, what does that form look like? And then how do we pay for it? The payment system is still front and center, because if we don't figure out payment, we're never going to get that optimal form. But what we've done so far in this industry, if we've just assumed that the payment system is the payment system, and we've created all of this, the form has built itself all around providing sick care to meet the payment system.
Totally agree, Eric. I just want to make sure we don't underrepresent the importance of that finance. And I didn't hear you say that, so I'm not disagreeing with you on that. I just want to make sure that it's clear in the report itself that in order to achieve what we're talking about, the finance system is going to have to be one that will generate these results. It's a systems approach, basically, once we get this in place, but we do have to have that vision. That's why I think that vision is incredibly important in that regard. But the visions in the past have not been aligned. The ones that I talked about were not aligned behind a change in the payment system. We kept paying for sick care despite these great visions we put together.
Yeah, because that's
well, I would jump in and say that I think a lot of the transition and the work that has been accomplished over the past 10 years is because there has been a vision of population health out in front of us, and it drives our creativity and our innovation. And it might be slow, and it might be cyclical, one step forward, one step back, another step forward, but it's the ideas that pull us into the future and allow us to trial and pilot different ideas. I think we've come to the place where by articulating 2030 as a beacon for population health, the work that Eric and Dan is doing is going to move us into that trotting versus baby steps. So we're starting to get some traction, but I think it's because we've been able to articulate a vision that people can really grab onto. And those are some basic theories of change, right? I mean, give a group of people something to look towards, and the creativity will get them there. So I'm really excited about this, and I'm really affirming and agreeing with everything that's been said so far.
Let me get through the last. This is where Dan gets all excited because it's the actual finance model. But we're not going to hit on every single one of them because after seeing two of them, they just kind of repeat. So some of the model assumptions is, the current system includes any investment in healthcare. And so we wanted to start with the optional function. What do we want in our rural communities? And again, we talked about access to sick care, but investments in health, wellness, et cetera. We believe a global budget payment system maintains a predictable and steady revenue stream so that the local healthcare system can maintain access to high quality sick care while investing in community health. And I saw this happening in Pennsylvania. I was at a hospital. Dan, were you with me in Endless Mountain, Montrose, Pennsylvania?
No,
okay.
I was not there at that particular time, no.
Okay. Anyway, they had received a global budget, one of the first 5 Pennsylvania hospitals. And they were rolling out their transformation plan. They had just received it the first of the year. August, they were developing this whole program around diabetes management and COPD, where they were looking to kind of take those 2 chronic disease conditions in their community, make a huge dent in them. That doesn't happen in fee-for-service. It doesn't. And they had invested pretty substantially in setting up this program. So we believe this global budget gives the hospitals predictable revenue stream. And then we believed a shared savings incentive creates an opportunity for the rural hospitals, at the base primary care level of providing sick care, to have incentives to create health for downstream revenue. All of that is being referred out of the system, out of the rural community. And so the model that we're going to do is a movement to a global budget at the local level, and then a shared savings incentive on a total cost of care. So it's a combination of these two. And again, it's interesting because the chart model, path 1 of the chart model was the global budget. Path 2 was the accelerated or the advanced payment model, ACO. So the models, what we assumed was at 2017 to 2021 was the current payment system, which was fee-for-service and cost-based payment for the critical access hospitals. We assumed a 2-year transition period, 21 to 22, which was, we moved all payers to a cost-based payment system unless their current fee-for-service revenue was greater than cost. And then for 2023 to 2030, we assumed all payer global budget model based on prior year revenue trended forward, and then a shared savings based on cost of care. So that was the model that was the high level how we built the model. Data, you can see we pulled the data from Medicare cost report data. We pulled global budget revenue based on trended data. So all of this was pre-coded data. Some assumptions that we made, we assumed a 3% increase in inflation for healthcare costs, healthcare spend inflation factors. So the total cost of care for each of the populations in these 4 communities, we assumed a 3% inflation factor for those. We assumed that the price increases that we could negotiate with third-party payers and Medicare was a 2%. And that's being played out. We assumed that we're going to get 90% of the population in this cost, or this all payer. We're going to get 90% of the payers in this payment model. We assumed global budget increases, so tied to inflation. This is what Pennsylvania is using right now. So in terms of the global budget in Pennsylvania, they're starting with last year's revenue and then they're inflating it by inflation. We assumed that for any shared savings dollars that we were going to invest back 50% of any shared savings into expenses, into the cost of developing a health and wellness system. Then we just assume some other modest increases. Dan, and feel free to comment on anything if I missed anything.
Yeah, I was just going to say on the back slide, that 50% where we're saying we're going to reinvest into healthcare and wellness, that is really where the hospital or the community gets together and says, where are we going to put these dollars? Where are we going to be able to actually create healthcare and make people healthier in our community? And I think that's where a lot of your work, Cap and others, come in. So yeah, that's where those dollars are going.
It's really exciting to see that in the financial assumptions.
And were the Medicare claims based on Minnesota, Eric and Dia?
The total cost of care was, Dan, I believe we pulled out per capita costs from Minnesota.
Yes, so I had to pull it. It was from the Kaiser Family Foundation of the per capita cost for Minnesota. And actually I had to trend it forward because they quit grabbing or showing that data after, I think, 2016. So, but that is roughly about the average per capita cost per Minnesotan.
So some of the shared savings in each case. So here was the healthcare spending per capita. This was the information from Minnesota. The latest information we had was 14 and 17. And that was off of Kaiser Family Foundation. Let's see, total service. So we took each of the communities and we took the population from each of the service areas that were associated with these demonstration hospitals. The yearly growth is specific to those populations, and it was the estimate of population increase or decrease. We assumed 90% of beneficiaries were going to be attributed to this type of a shared savings model. We assumed that if they were able to create shared savings on the total cost of care, it would be a 50% savings. And then we actually assumed savings on the total cost of care starting at 3% in 2021 and then going to 12% in 2030. That we're starting to get our arms around truly creating health by the time we move out into the future. So the financial model, for each of the cases, we did a base case. This was based on their 2018 cost report.
Correct.
Schedules off of the Medicare cost report. We looked at traditional patient revenue, other revenue. We looked at their expenses and their net income. So this was Charlie Pines. And Charlie Pines, you can see, and again, as you trend this out in the fee for service with no utilization increases, a 2% increase in fees, and then inflation going up 3% a year, obviously just the math on that, you're going to lose more money each year, right? The math just doesn't add up. And so you saw that there was an increase in losses each year, maintaining current payment systems that we have today. We then modeled out the new payment system. And as you can see, the 17, 18, and 19 and 20 were going to be based on traditional revenue. 2021 was going to be all payer cost-based. So we were going to gradually transition to global budget by essentially taking the third-party payers, commercial, Medicare, Medicaid, and transitioning into kind of, I think we used cost, right? It was cost-based payment, 90% of cost.
Yes, that's correct.
And then we trended that forward. We actually tied that to cost. And then from here, we moved towards global budget. And again, using the Pennsylvania formula, which was prior year revenue plus a 3% update for all payers. We assumed, and there's the next slide actually shows the shared savings model, but this hospital then created shared savings. This was, remember, 3% going all the way to 12% out in outer years. Here was the investment in health and wellness that we assumed down here. It was going to be 50% of any of the shared savings we were going to invest in back in health. And you can see that under this payment system, that the hospitals reduced its losses pretty substantially to the tune of the dollars here. This is the change, this is the variance in dollars. The next slide then actually showed the shared savings, was the summary of the shared savings, where this was the total spend for the population. And this was a small population. I believe this is Cook County, Charlie Pines, and a very small population. And so very limited spend. So in this case, the net savings, we never really got to true net savings because the population was so small. But again, here was the total cost of care, created shared savings. And the health system got some of those savings, and the net was. I'm just going to go through one.
And I'll say before we jump to the next one, Charlie Pines was the only case where we didn't get to shared savings by the end of the projection, and it really truly was because one, their costs are so high per population. Per capita there because the population is so small. So Eric, I'll turn it back over to you there to jump to the other case, because the other cases all kind of follow the suit where they actually are able to generate total net savings. So back to you, Eric.
So the next one was Delta Lake. Now, this was a much larger, hospital here. The traditional revenue was in the, $50 million range, expenses. And this hospital, they were making money. And again, the assumptions were that they were going to make less money every year because their price per unit of sick care service was going to go up 2%. No increase in utilization based on all the things we talked about. And so over time, when we start looking out on a longer term basis, ultimately they're going to go to a loss position. So in this model, we had, again, this is the traditional payment going across the top, the transition in 21 and 22 to this all payer cost-based revenue. And then the global budget, taking the revenue in 2022, adding 3%, and then trending it forward each year by 3%. Here's where you can see the shared savings revenue. I'm going to jump to the next slide. And I promise you guys that this is the last model we're going to show, because the other two are going to be just like this, and then we're going to summarize. But you can see that the total spend for this community, based on Minnesota per capita costs, multiplied by that population, you were looking at over $220, $230 million. So when you start talking about a 3% shared savings going to a 12% shared savings, this is real dollars. And so, shared savings here, and the shared savings comes in right in this part right here. We invest in health and wellness. And you can see that this hospital maintained and increased its margins going out into future years.
And just to speak to the point where we were talking about can you do with the shared savings, or how do you pay for some of these things that Cap and your team have come up with? I mean, imagine all of a sudden having a $1.8 million budget that grows to $5.4 million by 2030, that you can take $5.4 million and reinvest in a community to create more healthcare. I mean, that's a pretty substantial budget for a rural community to be able to all of a sudden say, let's take a look at what things we should have to create healthcare in our communities.
Yeah, thanks, Dan, for saying that out loud. And I think that is exactly the what our summit participants were frustrated with, is not knowing how to pay for the things that we know are needed in a community to have people be healthy, versus just reacting to the sick care. So having it be a line item in our expenses makes it legitimate, so to speak, that we're planning to spend this.
Yeah.
And Cap, it makes this project different, because in all the visions that I've seen before, we never figured that piece out. And so I think that's what makes this extraordinary, is that if we put these in, and this isn't a pipe dream, we've got 15 of these global budgets that are being sent out here, just through our chart models that just recently announced. So it's really great timing to put something like this together, but it brings the pieces together into some sort of a reality possibility.
Well, again, Terry, so
Eric,
let me just comment.
Sorry.
Again, the chart is the global budget revenue. This is the chart track transformation, the advanced payment model ACO, which you invest in healthcare. So what we've actually done in this model is we modeled both tracks of the chart into each of these communities. Not sure we're going to be able to do it, but as we see things, to meet those functional imperatives that we want in our communities, you got to have both sides of this thing.
Yeah, absolutely. Great. Good work.
Sorry, Dan. I'll cut you off, man.
No, I was just going to say, on the next slide where you show the shared savings, I know you had jumped to the next slide there briefly, the fact that the total healthcare spend, you have net savings, yet you also have money to reinvest in healthcare. And that's the unique thing about the other cases. It didn't work out in Charlie Pines just because the uniqueness of Charlie Pines, but in all the other cases it did so. So you have a total net savings of the total healthcare spend, yet you still have money to invest in healthcare.
So what you're saying, Dan, is the net savings here, this is what's coming out of future premium dollars for the community. So you're ultimately bringing down the cost of care, and at the same time, being able to provide enough dollars to sustain the health system, and enough to sustain the health system while having that health system invest in healthcare.
Correct.
Okay. Right on. And again, this is similar type models. Base case fee for service for Alphaville. Same type of modeling assumptions. And in this case, base case variance. So it was very successful relative to the fee for service model. And in this case, again, total net savings to the community when the total cost of care is 160 million. Just total savings back and giving back to this community in the form of lower premiums. Same thing for this community here. The significant improvement over base case and giving back to the community. So, our conclusions here is that, and you've heard this loud and clear, fee for service payment precludes our healthcare system from investing in community health. Period. End of story. The payment system that's modeled in this report is essentially chart 1 and chart 2. Global budget with a combined shared savings for reduced total patient cost of care. The global budget allows the access to sick care with investments in community health. The juice that you get out of shared savings on the second track allows us to really invest and gives us significant incentives to do that. All cases under the base case projections show deteriorating margins. In all cases, under the global budget and shared savings improved, and then 3 of the 4 cases generated net savings to the community. The only one that didn't was the very small population of Charlie Pines. So that's our report. You know, I think, you know, I know this is right. I know this is right. We've got to move payment, and we've got to take on a payment system that looks like.
This is great. Thank you so much. Dan, did you have something else?
No, well, I was just going to say, you know, back to one of the earlier points where we were talking about the kind of the debate between whether finance or function and where do you start. I think what's been interesting recently is you've started to see kind of just leaps when it comes to rural healthcare transformation. You look at Pennsylvania and their global budget that they rolled out, and the whole country is kind of looking at that and saying, well, is this going to work or not? And I think one of the things that maybe Pennsylvania lacks is that shared savings wraparound. And it's funny that now recently with the 2 different tracks that came out, how Eric and I have believed that you really have to combine them, because you have to offer that carrot with the shared savings along with stabilizing the current operations of the hospital with a global budget. So I think that's why both of those components are so important. Some of these hospitals need stabilized first, and then they need the incentive to start to create the healthcare and the money to start to create the healthcare in the community. So they really do go hand in hand.
They really do. And I think another way of saying that, what comes into my mind is from the beginning of this transformation, the question is, how do we share the resources with the community? Because to the point that a hospital can't do this alone. So this combined effort means everybody also has to get that incentive so that they can afford to do it, because the community members are really struggling to figure out how can we afford to improve the health of our population. So it's that collaborative effort that you are demonstrating in this model, and just total kudos for that. Other thoughts or questions while we have Eric and Dan here?
I have a question. So, you know, with a payment system like this, and given the state of the population of the various communities, we're seeing, you know, an aging population. We're seeing some of those communities having less access to things like broadband internet. We're seeing higher median income. We're seeing different trends in the population. How do you balance a model like this against some of the social trends of, like, in rural healthcare settings, you're seeing misutilization of ED visits and things like that. So what does a payment model do to ensure a better behavior of the population for utilizing services?
So I've got 2 responses to that, and you got to kind of combine them. The first is, right now, we have every disincentive to do that, to have any involvement at all in our community's health. We are completely disincentivized from doing that. So picture a world in which we actually now had an incentive to participate in community health. The question I have is, would we take a more active interest? Now I'll give you an example. Maine Health. Maine Health has a PHO that's been going on since the mid-1990s. Years ago, they decided because they get constant demand. We are the big system. They are the big system here in Maine. They're always full. They don't worry about volume. And they had a PHO that said our commission is around creating community health. It put healthcare coaches in the PHO. They put healthcare coaches in all of the primary care practices. Any chronic patient that came in to the primary care offices were seen by health coaches. The health coaches were funded by, kind of Sigma and Anthem, funding like a $5 per member per month case management fee, funded the PHO. The PHO had 50 health coaches, and we're really actually took in any like I said, any chronic patient that came into the into the primary care practices were seen by a health coach to start talking about things that they could be doing, and it's because they were getting paid for it. They didn't care about volume. And they were getting paid by the commercials for kind of a case management fee. Now again, I mean, they were doing it. There was still a disincentive for them to do it because ultimately their fee-for-service volume in the hospital would come down with more health. But because they're one classic example, they weren't worried about volume because it would always backfill. Where other hospitals that are running, 40%, 50%, 60% occupancy, they're going to do everything they can to get patients in. Those are the ones that are praying for the snowstorm and the ice storm so the people fall down and break their hips. I want to, one, create the incentive through finance, and then two, watch what happens when these incredible resources that we have committed to healthcare, right, or sick care, partially can contribute to healthcare. Look at our industry, the intelligence, the science, everything that we have in there. Give me a chance to deploy some of that in healthcare, but let's pay for it. So anyway, two-part comment or a response to your question. I've seen it happen. I've seen it, and it can work.
And I'll say, just to speak a little bit to the social discrepancies or the demographic discrepancies of the communities, like Eric said, there's so many different opportunities and different ways that you could solve some of the access issues with, depending on different demographics, whether it be healthcare coaches or even utilizing technology by giving patients devices, whatever they may be, to be able to reach out to the patient or push messages to the patient. I just think that there's so many different options, especially when we've looked at, whether it be picking up the patient to take them to their appointment, even spending money on transportation to get patients where they need to be, or nutritional help. I just think when there's money available, the options really do grow. And so there's not going to be, one blanket solution or even one solution for all the communities. But I think when we start to look at some of the substitutions that are out there, if we can employ some of these into some of these smaller communities, the rural communities, and the health system can help roll those out, I think there's a real availability there to help even the playing field with some of the discrepancies in demographics and social determinants there. Because each community is going to have a unique social, different challenges for their population, and maybe with money there, they'll be able to overcome some of those. I don't know, does that answer your question?
Yeah, thank you.
Great.
Yeah, I wonder, and this is fascinating to see the 2030 projection. Have you done this before, Eric and Dan?
Well, I think one of the things that was really fascinating to me actually was I didn't individually build these models. I actually built a model, and then I connected it to the data and just looked to see where the cards would lie. And it was kind of surprising to me I actually was a little bit surprised to find out how much savings there were, even at, a modest 3% or 4% or 5% total shared savings. So that was surprising to me because I didn't look at individual cases as I went along and tried to tweak the assumptions. I just put some assumptions in and then dumped all the data in to see where the cards would lie. So I think that was one of the interesting things about this.
Let's get excited about engaging this incredible resources that we have into healthcare.
Yeah, Thank you both very, very much.
That'd be
And
great.
have a great day.
Okay, bye.
Everyone.
Yeah, thank you.